Thank you, sir. And I'm extremely glad to be here. Thanks for the invitation, Arthur. So I think most of the panelists have actually done what I'm supposed to do, some of them. So most of them has already been done. So thank you all for the wonderful presentations that you put across. You said my name is Raphael. Last name is Quansah. Initially, I'm original from Ghana, and then I did medical school in Cuba. And then after that, I relocated to Jamaica. I spent about 10 years working in the hospitals. And then after that, I had a private practice myself somewhere in Lucy, those that are familiar with Jamaica. So then after that, I relocated to the United States where I did residency. I had a resident colleague who is also from St Kitts as well in the residency program. So after the 3 years of residency, then I came to Alabama, where I have been for the past maybe 6-7 years. And over here, my primary job is hospitalist, so I work mainly in the hospital. Do admissions from the ER, see how they come in, admit them, treat, discharge those that can be discharged, pronounce dead those that don't make it, unfortunately, transfer some to higher level of care, and eventually, those that also need other subspecialty consult, we arrange all that. So when the COVID hit, it just became very clear that we were the hospital service was one of the main body or the services that would be right in the middle of the management crew. As we talk now, people still think that probably the COVID is not real. And I think the first thing I want to say is you've heard from most of the panelists, COVID is real. And you cannot overemphasize that much. We just have to understand that this disease is real. And I think some of you that are listening only see the very mild cases. So that will give you some assurance that, most of the disease is just a mild and nothing is really wrong. And that is a very wrong perception. The disease is real. The disease is very devastating. And both the acute phase and the convalescent phase. So let's all take the precautions that we need to and fight this devil. This COVID-19, not the first time we started hearing about it was somewhere in December when it first came out in Wuhan, China. At that time, in the United States, we thought it was kind of too far from us. So, and I think it's the same thing that happens everywhere. And I'm kind of just passionate about the Caribbean because of all the links that I have. And I don't want, in some way, I think it took the United States by some surprise. And I just want us all, both the Caribbean, even back home in Africa, I want us to be on top of this and recognize it right from the beginning that this is real. And preparations have to be put in place to fight this devil. So in December, when this all started, I think Johns Hopkins created a website that they kind of follow the incidents and the mortality and everything that goes on. And before we even came on, they had reported that there is about 171 million cases of COVID-19 in the world. United States alone has about 33 million. And the death in the United States, I think some of the panelists have already said, is 595,808. And probably if you go to the website right now, the case, there are more cases and probably there are more deaths. So this is real. It's not like somebody is making things up. These are people that we have seen in the front line dying. And unfortunately, at that time, family members and their loved ones could not even be there with them. So the only people that could be there, hold their hand, pray with them, and let them take their last breath were we, the healthcare providers, which sometimes you finish and you come home and you cannot actually help but just cry whilst you're driving home and when you reach home. So as I said from the beginning, most times people see the very mild cases and they say, okay, then really nothing is wrong. But the CDC came up with some form of classification and the definition of how the disease, the disease itself is. And we know that, severe disease was classified as, people who need hospitalization, admissions to the ICU, people who need intubation or mechanical ventilator support, and eventually those who die. Earlier on, sometimes in May 2020, when we were just initially gathering the data, it became very apparent that about 14% of those that will eventually have the disease will end up in the hospital. And out of that 14%, you could be assured that those that needed to be hospitalized were 6 times more prone to have comorbidities, which most of my panelists have said, and I'll probably go into more details in some of them. 2% were admitted to the ICU, and unfortunately 5% died. And out of the 5% that died, they had 12 times comorbidities associated. And they had about 8 times other organ dysfunctions, which I think Dr. Lee Lewis made mention of. In the early on when the disease came up, I think the CDC from China put up a data about the case fatality. And it became very apparent that 8% fatality rate was in people that were older, and about 70 to 79 years old, and about 15% case fatality people above 80. So one of our main concerns became very apparent that the disease targeted age. And most of the literature has revealed that, age is actually one of the very first or the number one comorbidity that we have. And that is why I usually call upon all of us the moral duty to protect the elderly, because we know that, more than 8% of those who get the disease will, if they are old, 70 to 79, they will die. Now, if they are above 80, that case fatality rate even goes even higher. So it is, yeah, I understand the younger don't get the disease, they don't get the severity of the disease, but then it is our moral obligation and responsibility to protect our grandparents, to protect our parents, to protect the aunt, to protect our church member, to protect our priest. And that's what I think we have to do, because otherwise then we are failing the generation that gave life to us. So that is about age. Now, the other thing that also became apparent in the studies was that people who were in long-term care facilities and nursing homes were more targeted. And I think partly is because they are in an environment that the virus is very easily diffused, and they are also old, and they have multiple comorbidities. So it just became very clear that the target was very apparent. The other comorbidities is about sex. In our ICU, we saw a lot of males being primary target of mortality. Some women also died, but we think that more men died. And when you review the literature, male sex is actually a higher risk factor for mortality than the female. It appears, the sex hormones have some protective properties for the women than, for the men. Now, the chronic comorbidities that other panelists have all said about, literature have revealed that, probably about 32% of people who contract the disease and go to hospital have probably cardiovascular disease. And the cardiovascular disease, I think Dr. Lee and Leonard made mention of most of them. Under the cardiovascular disease process, we have the heart failures, we have the coronary artery disease, we have different types of cardiomyopathies, and then we have the big thing that predominates in the Caribbean, which is hypertension. And most of the patients that I have seen typically have either one or two comorbidities. And anytime you add one or two more on top of that, it just kind of raise the mortality even higher. There have been many explanations as to why cardiovascular disease is a major comorbidity, including number one, that there's a vascular endothelial dysfunction itself. There's also a lot of inflammation associated myocardial depression. We've seen a lot of stress related cardiomyopathy in the setting of COVID. And then there is the host response itself that worsen their underlying, like their heart failure or their coronary artery disease itself. So it just becomes a cycle whereby the disease is doing one thing, but then your baseline underlying medical problem itself also becomes completely decompensated because of what the virus is doing. And then diabetes mellitus. 30% of people that come to the hospital that we've seen, those we're talking about the severe cases, typically have diabetes mellitus. And it can be the type 1, it can be the type 2. The one that we typically see in the adult is the type 2. And if it is a diabetes that is not very controlled, it's worse. But it doesn't really matter. Once you have diabetes mellitus, it's just a major risk factor to have a high mortality than people who don't have diabetes mellitus. And then we have chronic lung diseases. Among the chronic lung disease, we have COPD, we have asthma, we have interstitial lung disease, cystic fibrosis, pulmonary hypertension. And when you add all these, we think about 18% of people who get hospitalized typically have this type of lung disease. And anytime you have one or you have two, your risk of going to the ICU is higher, your risk of mortality gets higher. Cancer. And they've actually typically found out that hematological cancers typically seems to be a little bit worse, poor prognosis than the solid. And among the solid cancer, lung cancer, and then any type of metastatic disease is a major risk factor. CKD has already been said. Obesity is a very big thing. here in the United States among, the population that I take care of, and also the population I used to take care of in Jamaica. A BMI more than 25 is typically what is considered an overweight. Most people have way more than that. Most people are between 30 to 40, which is really determined as obese. And then when you go above 40, we call that morbid obesity. And the morbid obesity implication is about tenfold, because just the risk of even intubation, if you need that, becomes a problem. There's multiple other things, medication bioavailability and all that becomes compromised. So it just a whole lot of things that happen when you have this morbid obesity patient that you have to take care of. That's why it becomes a higher risk factor. Sickle cell disease. And I kind of wanted to bring this up because it's a disease that is very common in our race. I think I saw more sickle cell diseases in Jamaica than I've seen in the United States. It's been identified as one of the risk factors. There's actually one common crisis in sickle cell, which is acute chest syndrome. The radiographic changes is almost similar to what we see in the diffuse pattern, like COVID. So if somebody get COVID and they develop that acute chest syndrome with sickle cell, that is going to be very devastating. So that is something to keep in mind. Now, immunocompromised states, including primary immunodeficiencies, prolonged steroid use, and the use of immune modulators have all come into play. Transplant recipients, so it can be solid or it can be blood stem transplant. They've all been part of higher risk group. There's been some debate that pregnancy or recently pregnant people are also higher risk. And that becomes very imperative that, anybody who is planning to become pregnant gets the vaccine, because your risk of, disease complications and disease severity is a lot higher than the non-pregnant population. In what I do, which is, seeing the patients in the emergency room, determine where to admit them, if they go to the regular floor, they go to the ICU, there is this severity of symptoms, which we know, as I said, 81% will be fine, but then you have 14% that are going to be admitted. And those patients typically have shortness of breath, they have hypoxemia, which is very low oxygen, or oxygen saturation of 93% or less, or when you have maybe 50% of their lung involvement. Now, critical disease is when you have respiratory failure, or when you have maybe a shock or multi-organ failure. And for those people, mortality is actually extremely high. So I think most of the other panelists mentioned a lot of these risk factors. All that I just kind of wanted to bring to your notice is the disease is real, and the more risk factors you have, the higher the mortality. And either with the Black race or the Caribbean or even the Africa, we tend to have more of these risk factors, and we just have to take the disease more seriously. The disease COVID-19, to me, the area to target or to fight it is not hospital. Once they come to the hospital, the battle is almost lost. We have measures that can prevent the virus from entering into our body, which is social distance, which is face masking, quarantine if you're feeling sick. And then we have measures that we have to use to fight the disease itself, And the best that we have so far is the vaccine. And since we have the vaccine, I can tell you that our ICU is almost back to where it was. We are admitting very little patients with COVID. And every COVID patient that I have admitted now is somebody that has not had a COVID, that has not had a COVID vaccine. So that is the trend that I'm seeing. So please, let's get a vaccine when it is offered. It is safe, it is secure, and the side effect profile is very minimal. I think there are so many people that I attended to who died that if I had offered them the vaccine, they would have jumped on it on the first offer.